Our next speakers are Ellen Sexton and Andy McMahon, both with UnitedHealthcare. Ms. Sexton is the Chief Executive Officer of the UnitedHealthcare Community Plan in Wisconsin, where she directs the strategic development and operations of the health plan, which serves 170,000 Wisconsinites through our state Medicaid program. Mr. McMahon is the Vice President of Health and Human Services Policy at UnitedHealthcare Community and State, which serves nearly 6.5 million Medicaid members in 26 states in the D.C. In this role, he focuses on integrating affordable housing and human services for populations with complex health needs, and he previously worked, among other positions, with the Corporation for Supportive Housing. Thank them both for being here today, and we'll take it away. Make sure you got the mic button there.
Sorry about that. Thank you for the opportunity to join you all today. And I think I want to start off by applauding Milwaukee. It's just incredible work. And if anyone questions it, feel free to call me and I can send you evidence that fills this room that proves that what he's talking about is absolutely right. So just a huge thank you for your leadership and the work you all are doing. As Sam mentioned, I'm with UnitedHealthcare, and we actually operate in 27 managed Medicaid health plans across the country. I'm going to provide an overview of what we're doing and what we're focused on in various markets, and then Ellen's going to do a deeper dive on what we're doing here in the great state of Wisconsin. But I think the first thing I would say is kind of we're a healthcare company, so why are we here talking to you all about housing? And I think my esteemed colleagues have already done a great job of talking about this, but I want to kind of highlight a few things. First and foremost is that, as Jim mentioned, housing is the necessary platform for healthcare. None of us in this room, none of our family members or anyone else will succeed in any host of other things without safe, decent, affordable housing as that foundation. And so as a healthcare company, as a managed care entities, we recognize that, and we have a whole host of Medicaid lives and Medicaid members that are in our plans across the country who don't have safe, decent, affordable housing. And what that means is that they have very poor health outcomes and they have very high utilization of healthcare services. And unfortunately, most of those services are emergency in nature and cyclical in nature and expensive in nature. And they're not preventative, and they're not the things that we really want to be focused on. And so this slide just gives you a quick overview. I'm happy to share all the data behind it, but it just demonstrates in part what Jim talked about, but the impact of getting people who have acute healthcare needs and histories of homelessness and housing instability into safe, decent, affordable housing has an enormous impact, most importantly on their health and their health outcomes, but also on their utilization of services. And so we've talked a good bit, and thank you, Dr. Curtis, for laying out, I think, a great kind of survey of the need and how acute the need is and how severe the need is in Wisconsin and across the country, which gives me the opportunity to really focus on what we are doing as a healthcare company to try to expand housing opportunities for our members, but also pursuing opportunities where kind of all boats rise for our members and other plan members as well. And so I'm going to go over briefly kind of the three-pronged approach we're taking to expanding housing opportunities. I would say at the outset that it's really important to know that these need to be integrated, and we need to do all three of them. This is a really complex and acute issue. No one way are we going to get there from here. And the other thing I want to mention as we talk about this is that all of these things that we're doing are outside of Medicaid financing. So when I talk to you about some of the investments and other things we're doing, there's no Medicaid billing that comes to us or anything like that. These are investments that UnitedHealthcare is making as a company because we think it makes sense. But I think what I would argue is that kind of together over time, we need to work to kind of better integrate and align our public and private resources across housing and healthcare from primary and behavioral health and the other social determinant areas that we talked about. So first I'm going to touch on investments. And I'm happy that I was on the right page, I think, as I heard some of my panelists. So we have what I would call a five-pronged approach to our financial investments in affordable housing. The first is, and I think Ellen will probably talk a little bit about this too, but nationally we've invested over $400 million in low-income housing tax credit projects across the country, and all of that really within the last 10 years. Lots of folks came knocking on our door during the recession, and they were looking for more investors at that time, and we got engaged there. So we are doing very significant investment in LIHTC projects, low-income housing tax credits. We are also doing direct equity investments. The kind of flagship for us is a project in Maricopa County in Phoenix, Arizona, where we invested very significantly to rehabilitate 500 units of housing and to recapitalize that project and make more than 100 of those units affordable to our members, and then also benefiting the broader community with the rehabilitation of the other 400 units. So we're looking at ways to replicate that kind of direct equity investment. Thirdly, we're looking at developing something I would call kind of informally a health equity fund, but thinking about how could we put together an actual housing fund that would not be project by project, but might be seeded by us at $50 or $100 million and say, we're going to go out and make these equity investments in affordable housing projects that have direct connections to healthcare and health and housing and integrating those things. So it would be a way for us to expand our efforts in the housing investment side. Fourth, we are exploring and have done some work already in social impact investing and pay for success. UnitedHealthcare is the senior investor in a pay for success project in Los Angeles County called Just in Reach. And fundamentally, what we're doing there with our investment of about $8 million is helping to finance the housing and services for 300 people who are super utilizers who sadly ping-pong between the Twin Towers LA County Jail and Skid Row, which is about 6 blocks away from the jail. And our investment will be repaid based on our partners' ability to stably house folks, keep them stably housed, and reduce their recidivism rates. So we have an outcomes-based contract with the County of Los Angeles where we are at risk. If this project doesn't meet the projected outcomes, then we risk not getting repaid. But we feel strongly, that it's the right thing to do, and we're very confident based on the evidence that the program will be successful. And I think the stuff that Milwaukee talked about is case in point for that. And lastly, and somewhat connected, and Dr. Curtis mentioned this, I really want to emphasize this point, is these low-income housing tax credit projects that we've been referring to have a 15-year life cycle of affordability, a 10-year tax credit to the investors, and a 15 affordability period. We are looking to make investments. Those projects that are coming up on their 15 years are called quote-unquote expiring use projects. So we are looking at putting together deals that will preserve and recapitalize that housing as affordable housing so that as we're looking to build new housing, we're also not losing ground on affordable housing that we have. So I think that's a really critical piece of the work that we're doing. So that's a thumbnail sketch of our work on the financial investment side. Now I'm going to talk about partnerships. And these are not unrelated from investments, right? These are intertwined with financial investments as well. But one of the things we realize at UnitedHealthcare, right, is that we're acutely interested and are exploring how we can make investments in housing. But ultimately, we need great partners on the ground in communities in Wisconsin and across the country to get this work done. And so we are embarking on and have developed a number of partnerships with an array of entities. So we're working with public housing agencies that are providing Section 8 rental assistance and public housing and tenant-based rental assistance, as well as project-based rental assistance, like it sounds like is at Thurgood Marshall, and trying to think about how can we partner with PHAs, and we're actually part of a national initiative where we're going to be creating formal partnerships between UnitedHealthcare health plans and public housing authorities across the country, recognizing that you all are providing the rental assistance and the other things, we can provide the connection to care And so we need to work much more closely together, is the short of that. Secondly, we're working with state housing finance agencies, and some of that could be around qualified allocation plans or QAPs, trying to push for prioritization of low-income housing tax credit projects that serve individuals and families with complex health needs and histories of homelessness and very low incomes. And so we are exploring ways we can work with the HFAs. Thirdly, we're engaging with continuums of care across the country, as also was alluded to in Milwaukee, not only with the housing authority and the housing agency working together, but also working with the local continuum of care, right, which is consisted of a whole host of the homeless service providers and supportive housing providers and owners, that our residents, our members really need to be connected to because they can be their residents. Fourth, we are working with Healthcare for the Homeless. Healthcare for the Homeless, for those of you who are not aware, is a remarkable organization. They exist in not every community in the country, but in lots of them. And it is an amazing combination of individuals who have actual medical skill sets and can provide some degree of medical care, but also have the ability and the guts and the chutzpah to go in and under the bridges and in and out of shelters all around downtowns and engaging with people and taking the time that it takes, which is a lot of time, to build trust for people, many of whom have had a lot of relationships that were not trustworthy. And so that building of trust is huge. And we recognize that our community health workers can be a part of that solution, but they don't necessarily have that exact skill set. And so we're looking to partner with Healthcare for the Homeless. We're also creating partnerships with affordable and supportive housing providers across the country. Dr. Curtis mentioned, with such a huge lion's share of this that is not necessarily publicly assisted. Our housing in our country is largely a private market endeavor. And so thinking about even in the private market where we can work with our members and connect them to housing. And finally is in plans across the country, we are hiring housing navigators on our own staffs to help people navigate the complex web of applying for various voucher programs or trying to help get and talk to the landlord and get into that unit that there might be some question about. And so that's kind of a overview of the partnerships that we are creating. Again, we can do a lot as UnitedHealthcare. I think we have enormous ability on data and analytics and provider network creation and all those sorts of things. But we're going to need all of these partners and more to make sure that all of our lives and all the members that we serve have a safe, decent, and affordable place to call home. The last piece I'm going to touch on is on the policy front, and I focused here on the Medicaid policy front. I will say we'll be doing other efforts around housing policy, supporting efforts around Section 8 vouchers, changes to the low-income housing tax credit program that could expand the basis, but the money that could go in for very low-income projects. So we're doing other things on the housing front. But on the specific to Medicaid, we are working on in a few primary areas. One is around 1115 waivers that states put forth to the Center for Medicare and Medicaid Services, CMS, and looking at an array of waivers that can help us expand the connections between housing and healthcare. And one of those is waivers that we've been supportive of in a few states and are looking at others where that would make kind of what we call quote unquote tenancy supports a Medicaid billable service. And so those are some of the kind of case management services, the things that we're talking about, the engagement of these folks that right, fundamentally anyone that has worked with a lot of these folks, those, trust me, are medically necessary for these folks, but are not necessarily seen that way kind of nationally in the eyes of CMS. And so we're working on waiver changes so that we can create a more comprehensive and sustainable financing system for those types of needed services. Secondly, we're working on whole person care pilots in a number of states around the country that are trying to endeavor to kind of create these connections across not only healthcare but housing and all the array of social determinants, and as the title suggests, kind of taking a whole person approach to this that is expansive of just their healthcare. And then the last but not least is exploring opportunities for value-based purchasing, right? Where there's a push for, I think rightfully so, to think about how do we pay less for volume and the number of times you do something versus the value or impact that something has on somebody's health outcomes. And so we are exploring opportunities, and that's a very complex issue, but we're exploring opportunities where we might be able to enter into value-based contracts that could also help our efforts to integrate housing and healthcare. So with that, sorry to race through, but that's kind of a quick thumbnail sketch of what we're looking at nationally, and I kind of I aim to go broader rather than deep, because I thought it was most important, I think, and I'm happy to talk to anyone afterwards, but to understand, at least from where we sit at UnitedHealthcare, that it has to be this multi-pronged approach. Like, we can't do one thing. We can't say, oh, we're not gonna buy our way out of this housing problem. We're not gonna partner just our way out of this housing problem. We're not just gonna change policy to get our way out of this problem. We're gonna have to work together and work across all of these and other strategies. So thank you. And with that, I will turn it to my colleague, Ellen.
Well, greetings. It's great to be here today among legislators, policy experts, community partners to talk about this important connection between health and housing. As Sam mentioned, I'm Ellen Sexton. I'm CEO of the UnitedHealthcare Community Plan in Wisconsin. That means that I, alongside my team, have the honor of serving 170,000 Medicaid beneficiaries here. At UnitedHealthcare, I think you can tell from Andy's overview, our mission is to help people live healthier lives and to help the health system work better. And if you think about the U.S. healthcare system right now, it's hard to navigate. There's rising costs. There's tens of millions of people that are still uninsured. And even though we spend twice as much as other developed countries, people are still not getting the health care that they need and deserve. So at UnitedHealthcare, we're thinking about that different. And one of the things is not to just think about the clinical conditions, but to talk about the social determinants, the things that are impacting people's quality of life, their economic situation, their job, do they have access to food, housing? These all matter to us. And as you can see, we can impact them and actually reduce healthcare costs as we do that. So Andy mentioned about a lot of the financial investments that we've been making across the nation, and I'm proud to say in the last 6 months, we've also made some here in Wisconsin. So the flats at Grandview Commons, that's on the east side of Madison. It's a 96-unit affordable housing unit. We invested $5.3 million from UnitedHealthcare. We worked alongside numerous partners. This is a true takes a village to bring things to fruition. So WEDA, Minnesota Equity Fund, and Senair were part of that. And then more recently in February, we broke ground at 704 Place. That's actually in Walker's Point. So Representative, I know, had to step out, but right in the area that we were talking about. And the awesome thing about 704 Place is that it has 60 units, but 14 of those units, I should say, are set aside for veterans and people that have been struggling with homelessness. In addition to that, it's not only about the affordable housing piece of it, but it's the wraparound services. There'll be on-site service support for them, case management to truly help those veterans and those that were homeless to get back on their feet and lift them up out of poverty. So as Andy said, we've been doing that across the country. We've invested over $350 million since 2011. We've brought 2,700 new homes to families. That means there's more safe and affordable housing for people to access. And I think it's a really unique and different way of thinking about how you can bring private and public together in housing and healthcare to make a difference. So Sam, I think, already showed these numbers to you, so they should look familiar. But what I want you to think about as I talk through this is that health is impacted more than just clinical performance. And so when you look at the right side of this slide, of course, it's clinical care, access, and quality care. Yes, it's your physical environment and your healthy behaviors around diet and exercise. But take a look at the left side. 40% is due to social factors. Do you have a job? Do you have access to quality food? Do you have transportation? Do you have safe and affordable housing? So many times I go and visit my members and it's a pregnant mom and she's couch surfing. Imagine being pregnant and not knowing where you're going to be living next week. You have a lot to deal with. That shouldn't be something that you need to deal with. So when we think about our case management, we focus a lot of our time, especially up front, on those social and economic factors. And I got to tell you, the case managers on my team, they are amazing. And it is about developing trust and getting people into the care they need. So our community health workers, Andy mentioned our whole person care model, and that really is getting out door to door, face-to-face visits, because a lot of these people have complex conditions and they're homeless. And we can't reach them unless we're going face-to-face. So meeting them where they're at is really important. And if you think about traditional Medicaid and the provider environment, a lot of health isn't happening in the doctor's office. It's in the environment that they're in. So think about somebody who comes out of inpatient. They've got a discharge plan. Maybe they don't even understand what they're supposed to be doing. That's what our caseworkers are helping them do. And so you think about some of the conditions that somebody is homeless is dealing with, right? So they could have poor air quality for an asthmatic, or a diabetic who doesn't have refrigeration. I have a story of one of my case managers. She went immediately home when she found insulin that wasn't being refrigerated, got a cooler, filled it with ice, and made sure that that insulin was now at the right temperature. Think about somebody coming out of an inpatient stay. They don't have food at home. They may not even have a home, right? So we have a program for our readmission reduction, and that all centers around making sure that people have 7 days of meals shipped right to their home. So all these things are creative ways of thinking differently about how we spend the money for healthcare, but also get better outcomes for the people that we're serving. So a big part of solving for this is the wraparound services that Jim talked about and case management. I wanted to spend a little bit of time talking about the myConnections pilot. So I wanted Andy to come today to tell you about some of the great programs we have across the nation. And what I get to do is bring that to Wisconsin. And so for the myConnections pilot, it really is the housing first notion that we talked about before. And if you think about people that are homeless, they are spending and overutilizing the wrong types of healthcare, so emergency type visits, and underutilizing the right type of healthcare, so preventative care or mental health. And they're difficult to case management, because half the time we can't even find them, right? They're transient and tough to locate. So if we start with the housing first approach and use that as a first access to get them back on their feet, the rest of this all follows. So what we're doing in Milwaukee is we're taking 10 individuals that have high utilization of preventable healthcare costs. So you're talking about $120,000 to $150,000 a year. They've got an average of more than 28 ER visits a year. And what we'll do is start with a housing first approach. We've been partnering with Milwaukee County Housing Division, working with landlords. We get them in housing. We then get all the social services wraparound, SSI, SSDI, get them Section 8 housing, and worry about their social services first. Then with our case management, we can get them access to care, mental health, and really get them back on their feet. The goal in the end, right, is to get them to self-sufficiency. So we'll be subsidizing this rent, just as Jim talked about for a lot of the folks that they worked with as well. And if you think about that math equation, it's not hard. So $700 to $800 a month in rent, $10,000 a year versus somebody that's costing $150,000. So that's the math part of it. Now think about that individual that's back in society, functioning. I was actually at the Thurgood Marshall Apartments. I think it was in January now. I know it was winter because it was cold. And we met somebody who had been living on the streets for 16 years, now was there for the last year. And he told me about how he had ridden his bike to his grandkid's birthday party. And he was talking about how he wanted to start looking for a job as a machinist. So you can save healthcare costs, yes, but we just returned somebody to living their life. And I can't think of anything more powerful to be part of. So I want to thank the Milwaukee County Housing Division. Your team's been phenomenal, and I think a lot of your goals align with our goals. So on behalf of the 9,000 other United Health Group employees that work in Wisconsin, I hope you can see how proud we are to be working in this space at the intersection of healthcare and housing. And then I ask you to help join us as you think about policy, as you think about how to partner with us to really help solve this. Thank you.